Hello and welcome to this Desira Clinical Education Oncology podcast. I'm your host, Jerfus Constanzo. Today's episode features Nadia Harbeck at LMU University Hospital in Munich, Germany, and Francois-Clement Bidard at Institut Curie in Paris, France. Together they will be discussing the role and emerging data for AKT and PI3K inhibitors in patients with endocrine-resistant breast cancer. This episode is part of a larger educational program titled Novel Targeted Therapies for PIK3CA, AKT1, PTEN Altered Metastatic Breast Cancer, Key Evidence and Real-World Insights to Optimize Patient Care. For more information on Nadia and Francois, along with the link to the complete program, including downloadable resources, clinical commentaries, and interactive case challenges, please visit the notes for this episode. Now let's hear what the experts have to say on this topic.
Hi, welcome to our podcast on the current application of PI3 kinase and AKT inhibitors in patients with metastatic breast cancer, areas of agreement and controversy. My name is Nadia Harbeck. I'm the director of the breast center at LMU University Hospital in Munich, Germany. And I'm very glad to be here today with Dr. Francois-Clement Bidard from Paris. Francois, do you want to introduce yourself?
Hello, Nadia. Francois-Clement Bidard here. I'm a medical oncologist. I'm working in Paris at Institut Curie, where I lead clinical research on breast cancer, and I'm also the vice president of the French Breast Cancer Group. So happy to be here with you to discuss the use of PI3K and AKT inhibitors.
Yeah, I think there's a lot to discuss because we just started to use the more modern compounds and there is new trials coming up. So I think it's a very fitting time to have a discussions. If you look at the patients with a primary resistance to neoadjuvant or adjuvant therapy and the first line therapy, what are your standards and how do you deal with that?
That's a good question to start with. Basically, we will divide the population, so the ones that are considered as having a disease which is resistant to endocrine therapy. So, of course, we'll divide it following what has been initially developed in the ABC guidelines, so which is trying to divide the primary endocrine resistance population. So patients who are relapsing during the first 2 years of adjuvant endocrine therapy or progressing during the first 6 months of the first line with CDK4/6 inhibitor combined with AI in patients with metastatic breast cancer. So we have this core population, small population of patients with primary resistant endocrine breast cancer. And then we have the secondary resistance, which is patients who are relapsing after 2 years on adjuvant endocrine therapy and up to 12 months after the discontinuation of endocrine therapy. And of course, also in the metastatic setting, patients who would experience a disease progression during the first line with AI on CDK4/6, but after the first 6 months on treatment. Basically, we have these two populations, which are considered as being somehow endocrine resistant. And then the key question is what to offer for this patient. First thing is we have to consider endocrine therapy. And then that's the first choice, and that's something we could discuss after is, should we go with the next line with an endocrine therapy agent, or do we have to introduce chemotherapy/ADC? So that's a question. I'm not sure we have the right answer, but we could discuss that later. And then if you choose an endocrine therapy-based treatment, then you have to think in terms of combination. What we know is that single agent endocrine therapy is unlikely to work for a long time, in most patients at least. So most of the time, the second line will be made of a combination between an endocrine therapy agent and something else, which is supposed to increase the efficacy. What is this something else? So it could be multiple agent. And so we could have sometimes re-challenge with CDK4/6 inhibitor. But what is most interesting is that in that setting of patient with endocrine resistance, what has emerged is the idea of targeting PIK3CA pathway, which drives the resistance to endocrine therapy in about half of the patient population. So that's what I would say. And when it comes to specific agents, maybe Nadia, you could remind people who are listening what are the current agents we have to target this pathway.
Yeah, well, I think you outlined it nicely with the endocrine resistance, and I think that's the only time point when we actually test for biomarkers in the first line setting is if you have a patient that comes very quickly on or within the first year after adjuvant therapy, and that's the time when we would test PIK3CA mutation, and if the patient has a mutation, we would put her on the triplet combination, inavolisib, palbociclib, and fulvestrant. I don't know whether that's available in France yet, but in Germany we've just started, so we would be using that. And it's not that many patients yet. So I cannot tell you how effective this is, in particular if the patient came from an adjuvant CDK4/6 inhibitor. But that's the only time when we would test in the first line setting, and otherwise in the first line setting, we would go for CDK4/6 inhibitor with an AI and then test in the second line setting. And I know that you've done this outstanding work with your own PADA-1 study, but also with the SERENA-6 study. So you would probably start already testing under the first line CDK4/6 inhibitor plus AI, at least for ESR1 mutation. Is that right?
Yes, so that's a good point. Yes, we have an interest in ESR1 mutation. So obviously, because we know the drive resistance to AI, and we also know that they are very frequent, about 40% of patients. So what is interesting is they only drive a part of the resistance to AI, and they are not driving resistance to other sets. Back to the time of testing, it's very important too, because the second line now we have in France. So at the moment, we don't have in the second line access to capivasertib, so we are still awaiting, but we do have an access in first line to inavolisib, and this is granted through an early access protocol. So it's very interesting for us to also have our first real life patient treated with inavolisib. So what is interesting and what could differ from country to country is the way to test the patient population. So what we do, we have two different settings here. So we have this first line for patients who are relapsing on adjuvant endocrine therapy. For these patients, what we know is that disease is likely to be quite aggressive. And these patients have symptoms during the adjuvant treatment. And of course, we need to put them on treatment very quickly. So it means that we need a fast turnaround time, very short turnaround time to get the biomarker results. And what we do mostly is to use ctDNA, which is non-invasive. And at my site, we have a turnaround time of about 10 days to 2 weeks to get the result, which is acceptable. With ctDNA, we know we will be able to capture most of the tumor with a PIK3CA mutation. We know PIK3CA is easy to detect, but not all patients may have enough ctDNA level in their blood. But most patients will have enough ctDNA level to catch this mutation. And catching this mutation would allow us to put the patient on Inavo plus Palbo plus fulvestrant. So that's what we are currently doing. When we have more time, which is patients that have an endocrine sensitive disease, so they are treated with first line AI plus CDK. And what we do at my site is that we test during the first line, so we have time to test the primary tumor or any biopsy, and we would do NGS on tissue. And that NGS would cover not only PIK3CA, but will cover other mutations such as PTEN and AKT. And we would be able to determine before the patient experiences disease progression whether they would be eligible for second line treatment, keeping in mind that at the moment we don't have access in France to capivasertib. I think you have access to capi in Germany,
Yeah,
don't you?
that would be our second line choice, where we follow the ESMO guidelines basically, and we have access to the drugs that are listed there. So in those patients that are endocrine sensitive or where we go for CDK4/6 plus AI in the first line setting, we would then test for PIK3CA mutation, AKT pathway alterations, and ESR1. We mostly do this in the liquid biopsy at that particular point. If we just test for PIK3CA mutation in the first line setting to see whether there's a NAVO indication, we may resort also to the tissue that we just collected to verify the metastasis. So we can do both for PIK3CA because it's a driver mutation more than it's not acquired. but for ESR1, I completely agree. Then testing in the second line basically would then tell us whether we have a patient that is eligible for an oral SERD. And so far in Europe, we only have elacestrant available. In Germany, we have both elacestrant and imlunestrant approved in Europe, but not available in the markets yet with regard to imlunestrant. And then we check whether we have a PIK3CA mutation, which is the most frequent also in the AKT pathway, or AKT or PTEN alteration, and then go for capivasertib plus fulvestrant. We don't use a PI3 kinase inhibitor in this second line setting because alpelisib is not available in Germany, and the toxicity pattern, I think, is more favorable for capivasertib. So that would be my second line choice. And then if you don't have an alteration, I think we can still use everolimus. It's old, but it's still good if you want to go for another line of therapy. But something you said, let me go back to the first line, Inavo. I just wanted to ask you, what do you do with patients? Because I don't think we have patients yet that have progressed on this triplet combination. Would you then take them right away to chemo, or would you still test for ESR1 mutation?
Actually, we will have this clinical setting quite soon because we started to have patients in real life at my institute. So we started in AVO, but it's very recent, so they have not yet progressed. But so what we know is when it comes to the PFS with AVO was quite long. It was 17 months, at least in the trial. So we'll see how it goes. So that's more than 1 year, almost 1 year and a half. So we'll see how our first patient fare and the combination in real life. So I think that these patients are of some endocrine resistance. They relapsed on adjuvant endocrine therapy. So obviously at that time, when they progress, we will switch to chemo. Yes, some patients may be eligible for a further line of endocrine therapy, but what we know is that they are not very likely to develop an ESR1 mutation because they have been treated in first line with fulvestrant. And we know that ESR1 are more likely to appear when patients are exposed to aromatase inhibitors. So there will be, of course, some ESR1 mutation, but not that frequent. And I'm not sure we have any data to show that there is a strong activity with any oral SERD given as a second line after PI3K inhibitor plus CDK4/6 after relapse in the adjuvant setting. So obviously, these patients will, at time of progression, will have very aggressive disease and will likely be treated with chemo. That's what I do. Of course, it will depend on the each clinical setting, so we'll have to discuss it. But obviously, I'll go to chemo. And that's also part of the discussion is when to balance the choice between chemotherapy, which could also be given first line, and other endocrine-based treatments when a patient relapses on adjuvant endocrine therapy. I know that we are sometimes proposing chemotherapy as a first-line option, and chemotherapy could include oral agents such as capecitabine. We could also consider TDXD. At the moment, we don't have access in France to TDXD as a first-line chemo, like in DB06, but we are using it mostly in the second line. So we would obviously request the HER2 low assessment or reassessment or rebiopsy. And that's something we have to keep in mind because it's balancing between attractive endocrine therapy-based regimen, but also we have very attractive chemotherapy or ADC regimen, so that could come with a very interesting efficacy. So I don't know at your site, how do you balance for patient? How do you drive your decision? Is it performance status or site of metastasis, or do you put everyone on endocrine therapy?
In the first line, we would try to give endocrine-based therapy to everybody. We don't do the Sonia approach, so we would always start with the CDK4/6 inhibitor unless we need the triplet combination as discussed before. There's hardly ever patients where we feel that there is so much disease burden and it's so aggressive that we should start with chemotherapy. And there were very good review in Germany from the Pregnant Network showing that that's probably 10 to 15% of all patients, and the rest will go down the endocrine-based route. And we also also would try to give more than one line. I completely agree with you that we don't know what happens after the triplet Inavo, Palbo, and fulvestrant, because we don't have patients that have progressed. We did not participate in the registration trial, so we're not sure. But I could foresee, because we've covered pathways, if it's a very rapid progression, we would definitely put her on chemo. If it's more like a slow progression or so, then maybe we would test for ESR1. If she's had ESR1 aromatase inhibitor in the adjuvant setting, maybe there is a mutation. So we would do that. And when it comes to chemo, I think we're tempted to give TDXD first line, because the data, I think, is very compelling for DB06. We just had a case like this in the tumor board, and was a patient that was actually a little bit frail, but we were asking maybe capecitabine, maybe TDXD, but the patients don't get better with the next line of therapy. So I think it's always good to give TDXD maybe in the first line as a chemotherapy, because patients may not have a good enough constitution that they can have it second or third line. So we're sort of leaning towards TDXD. But other than that, we're trying to give at least 2 lines of endocrine-based therapy. We would also maybe try a third line if there is a mutation that we can target. We usually do the capivasertib plus fulvestrant if there's a PIK3CA mutation in the second line setting, but also like an oral SERD by itself, and if there's an ESR1 mutation in a very slowly progressing disease, maybe a good option. But we also know from the ELEGANT trial that if you give like the oral SERD as a single agent too late, maybe a third of the patient will not benefit anymore and go rapidly, progress rapidly. And that would be the point then when we would definitely switch for chemo. Sometimes we have these patients with these co-mutations, and then there's always a big discussion in the tumor board. What do you do? So what would you do if you have ESR1 mutation and a PIK3CA mutation?
Yes, so that's of course a question that is very, let's say, recurrent. From the data, first, we know that we have 40% of ESR1 mutation at time of progression under AI. And we also have 40% of patients with PIK3CA mutation, and up to 50 if you take into account AKT and PI3K. If you combine PIK3CA and ESR1, so it's 40% by 40%. So at the end, it's between 15 to 20% of the patient population. So there is no mutual exclusivity or something. So it's really doing the math. 15 to 20% of the patient population will have this double mutation. And then the question is, of course, as you pointed out, what should we target? And of course, we are all awaiting trials with oral SERDs combined with agents that are targeting PIK3CA or AKT. But at the moment, we have to choose between single agent oral SERD, imlunestrant when available, or elacestrant, or fulvestrant, which is the old SERD combined with an AKT inhibitor or PI3K inhibitor. Of course, then when you look at the PFS, and you could look at the evidence, the PFS might look a bit longer with PI3K/AKT inhibitor compared to oral SERD, but there was some difference in the population. So it's not so easy to make a definitive call in terms of efficacy for PFS. When it comes to overall survival, at the moment, there is only one trial that has shown a benefit in terms of overall survival, and that trial is Inavo 120. So which means in the context of patients relapsing on adjuvant endocrine therapy, even though there is an ESR1 mutation, definitely in terms of level of evidence, I would go for inavolisib. Then the next question, when you really have a choice and you don't know what to choose, then of course you have to adapt your choice to the patient you're facing. And then it comes to the different side effects. And here, I would say that all SERD are overall very well tolerated when we have to face some real toxicities with agents that are targeting PI3K or AKT. So we made a lot of progresses since the first generation inhibitors, such as buperlisib or pictillisib, which were too toxic to actually make it to the market. So we had the second generation inhibitor, which were more selective toward PI3K alpha. And these include like alpelisib. We also had tazilizib in Sandpiper. So alpelisib was it's still available in the US, but approved in Europe, then not reimbursed, and at the end, it's not available anymore in Europe. Now we have like selective inhibitor of PI3K alpha. And so with Inavo, those toxicities getting better, but still we do have 2/3 of patients will experience hyperglycemia. We have skin rash, we have diarrhea, we have stomatitis, and could be also some dry eye effect, something. So these are toxicities that need to be discussed with the patient, and you have to adapt. The way to manage these toxicities is very important because we will all have a kind of training curve, especially for clinicians who did not participate to our registration trial. It will be our first-hand experience. It's something that is a lot of education is needed. For the audience, I just want to mention that there is an excellent paper that has been published in the very first months of 2026 and published in ESMO Open by Kamal Jhaveri. And you could find it on PubMed. It's open access. And it's just about all the toxicity of PI3K inhibitors, but also AKT inhibitors and how to manage it. And that's very important. You will have a very comprehensive table about the different action to take. And just very briefly, they will say what kind of assessment you should do as baseline, like decayed hemoglobin and so on, and what you could do in terms of preventive measure whenever you want to put a patient on metformin or not, and so on. It depends on the drug, it depends on the context. So this is something that is very basic, but it is needed. You need to know that before initiating a treatment with inavolisib. It's a kind of guidelines about the monitoring during treatment and also what to do in case of adverse events. I would encourage the audience to refer to that article. Very, very easy and also very important because we are not endocrinologists. So diabetes, honestly, I don't know what to do most of the time. When you're working in a large university hospital, you could always find an endocrinologist walking by in the corridor, but it could be that you're working in a smaller private practice and you don't have endocrinologists that are working around. So it's very important to keep that in mind. So final answer to your question is a balance between all third single agent and agent targeting PIK3CA. I would make the call based on the level of evidence. Overall survival is in favor of using Inavo. And then second is about tolerability and whether the patient has an overweight that could lead to higher toxicity of PI3K targeting agents. I remember when we used alpelisib in France quite a long time ago, the very first patients where it was a bit tough, and then it was better for the next one. We have to educate our community to how to manage, and to educate the nurse and the general practitioner as well. That's part of finding the appropriate patient for this agent. I don't know how do you do about whether you would send your patient to an endocrinologist to manage diabetes or whether you would prescribe metformin or do it yourself. Nadia, what would you do with this hyperglycemia, which is the most common side effect for these agents?
Yeah, we usually team up with a diabetologist. Maybe some patients already have somebody who can help us there, because in Germany, like a lot of the breast cancer doctors are trained gynecologists, and we know about diabetes from treating pregnancy and diabetes, but it's not something that we do so often. It's a network, and I think you're very right in pointing that out, that we have to create this network for these new agents, and that's true also beyond the PI3 kinase inhibitors. So it's something that everybody has to figure out for themselves. But then a nice thing is that when new agents come along, you already have these connections. And I found that the toxicity sort of gets better and better with these new developments. Like, for example, we participated in the Capitello study, and I couldn't tell after the first cycle which arm my patient was in. And I think that's always a good sign for a new drug, that the toxicity is actually very manageable. You mentioned alpelisib. It has completely probably disappeared from our management because we now use capivasertib in those patients. And there will be a trial, the Inavo 121, just directly comparing inavolisib with alpelisib. So we'll see how these newer generation of PI3 kinase inhibitors does, not just with efficacy, but also with safety. So I think that's one of the trials I'm looking forward. It's fully recruited, so we'll have that soon. And there was one thing that I was intrigued in. I'm also participating in the Inavo 122 trial, and it's about inavolisib in HER2-positive breast cancer. And you may ask why that, but there's this nice paper by Sybil Leubel showing that PIK3CA mutations in the early stage setting in mostly HR positive, HER2 positive disease actually a predictor of poor PCR in those patients. And they're kind of a resistance factor in the HER2 positive setting. So I think it's a very interesting trial where we have an induction with the Cleopatra regimen, and then for the maintenance patients with a PIK3CA mutation get randomized to inavolisib in addition to the regular maintenance versus placebo control. So I think that's an interesting, more outside the box approach to PI3 kinase inhibitors, and I'm really curious to see what the data will look like. You overlook the scene quite well because you're also participating in a lot of these targeted endocrine trials. Are there any other newer, even better developments in the PI3 kinase AKT pathway inhibitor field that you're excited about?
Yes, so there are, like, say, many developments. Of course, we have inavolisib, so which is the most selective, but still like ATP mimetic drug, so which is a drug that will block the enzyme. It's a kind of a poison. That drug, as you mentioned, we have a lot of trials investigating HER2 plus metastatic breast cancer. There is also Inavo 123, which is currently targeting the endocrine sensitive population. So it's basically palbociclib or ribociclib plus AI plus or minus inavolisib. So obviously, inavolisib will continue its development because of its favorable toxicity profile compared to other PI3K inhibitors. What is also interesting is the progress in chemistry. I mentioned, like, first generation, they were too toxic. They never made it to the approval. Then we had the second generation, like alpelisib, like a bit more specific for the mutant form. And then now we have something that is like more specific with Inavo. And what are the progresses in chemistry? Now we have allosteric inhibitors. So allosteric inhibitors, there are compounds that are inhibiting a mutated form of PI3 kinase, but they are inhibiting it not by binding to the enzymatic part, or to the enzymatic pocket, but they are binding somewhere else. These new agents are interesting because they are extremely specific for the mutant isoform. So at the moment, we don't have any of these agents in clinical routine. So it's not for today, but just for the people who are listening, it's interesting to keep in mind that chemistry is making progresses. We have two main compounds that are being developed. One is developed by Relay Therapeutics, and the name is zovegalisib, and it's currently in the second line trial with the Rediscover 2 trial. And we also have allosteric inhibitor developed by Lilly, which name is terzolizib, and terzolizib will be investigated directly in first line. So it's interesting to see, like, it's always about combination with endocrine therapy, and more combination also with CDK4/6 inhibitor. And that's the idea of to block HR positive metastatic breast cancer. You could combine blocking the estrogen receptor, blocking the CDK4/6 pathway, and blocking the PI3K pathway. So which is like blocking three key drivers of the tumor growth. And as already pioneered by the Inavo trial, so which led to the approval of inavolisib. Obviously, it's a way to block tumors for quite a long time. So we have to see what is the future with these new agents. But chemistry is making progresses, and this is explaining the new agents that we are seeing coming to the clinics and coming in clinical trials. And so we've made a long way since very first agent, and even also compared to alpelisib. So that's very happy to see the future development. I think that we could conclude about these agents. So we are at the very beginning, Nadia, of using both capivasertib and inavolisib in the routine clinics. And so it's something that will help us to understand and to manage the toxicity and finding the right patient to give them the best treatment option compared to chemotherapy and compared to other treatment options with endocrine therapy. And it's interesting also to keep in mind that in the long term, these agents blocking PIK3CA will play a greater role, probably even in first line, and even it could be in the adjuvant setting. So we have to wait to see that.
Yeah, I couldn't agree more. I think these are very exciting times. And I still remember those very early trials where we had side effects that were not manageable. And we had a patient getting into a maniac phase and going on a shopping spree. And so I think we've come a long way from then now to inhibitors that can be managed quite well, and where patients are not so bothered by the side effects for the majority. And I completely agree that we'll probably see some very intriguing data also overcoming resistance, and then maybe moving in selected populations, moving these drugs also in the early stage settings. It's very exciting. There is still data that we're waiting for. We're waiting from the Capitello trial, the overall survival data. Even if there is no advantage, I think these drugs are still very good in improving progression-free survival. And I'm still at awe of this median 2-year difference in median to time to chemotherapy if you use inavolisib in those endocrine-resistant tumors in the triplet combination in the first line. So I think exciting opportunities for our patients, and it was a great discussion. Thank you so much.
Thank you, Nadia and Francois, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Novel Targeted Therapies for PIK3CA, AKT1, and PTEN altered metastatic breast cancer, Key Evidence and Real-World Insights to Optimize Patient Care, and to access other online content associated with this discussion, please click the link in the show notes. As always, thanks for listening.